Good evening, everybody. My name is Ian Sharp from Exeter, and I'm welcoming you to the lecture distinction, which tonight is going to be on infection in the foot and ankle. And our distinguished lecturers this evening are Con, as he likes to be known, so he tells me, from Oxford, and Mark Rogers from Oxford, who are foot and ankle surgeons and also part of the bone infection unit there. So I'd like to thank our supporters tonight, Bone Support, for their kind support of the lecture. And during the lecture, if you'd like to put some questions on the Q&A chat, we'll answer those at the end of the session. Attendance certificates will be given at the end when we send you an automated email. But to do that, you have to have a code which will be presented to you at the end of the Q&A session. With no further ado, I'll now introduce Con for his lecture on infections in the foot and ankle.
Thanks, Ian. I'm just going to share my screen. Can you hear me well? And it's all good with the screen?
All good.
All good. Well, good evening, everybody, and welcome to the foot and ankle infection webinar. In the first part of the session, I will cover some theory and some principles, and then Mark will take you through a few cases as examples to practice for the exam. He will cover a couple of topics that I will not cover in this lecture, such as septic arthritis and implant-related infections. Now, in every case of a foot and ankle infection, I always consider three things. First, the location of the infection, from skin to joint, and I consider every layer. Second, what could be the microbiology, and never forget to consider fungal and mycobacterial infections. And third, what is the quality of the host and whether the host is compromised either in a local or systemic way. Oops, why is now? Sorry. Don't know why it's not changing slides. Let me just see. Okay. Right, we're going to start from the most superficial part of the foot, which is the Stratum Cordium, which is the most superficial part of the epidermis, and the nail plate is analogous to the Stratum Cordium. Now, onychomycosis is a fungal infection of the nail and nail bed and may come as a coincidental finding in your clinical exam. Also, things that may come at the MCQ is the fact that it's the first and fifth nails that are most commonly affected. And the causative organism, Trichophyton rubrum and Trichophyton interdigitale, are the same organisms that actually cause athlete's foot. Now, it can be painful, it can spread to deeper layers of the skin and bone, and it is contagious. Now, lab confirmation can come from nail clippings or nail bed scrapings, which is better, and therapy can be topical if the actual infection involves less than about 20 to 50% of the nail, or systemic. And on the practical side of things, if you consider surgical avulsion, always consider topical treatment afterwards. Affecting the deeper layers of the epidermis is tinea pedis, which literally means fungal infection of the foot. Now, it usually affects the interdigital spaces, but can involve other parts of the foot, such as the dorsum and the plantar aspect. Now, the most common is the chronic interdigital type that mainly affects the fourth interspace and the fourth and fifth toes. It can be itchy, it can be scaly, and this is what we know as athlete's foot. Now, there are more severe cases, and these are called Moccasin type or hyperkeratotic type that can involve the sole of the foot, and the vesicular bulbous or blistery type that can involve the dorsum of the foot. Now, causative organisms, diagnosis, and treatment is very similar to onychomycosis. Then we enter infection of the dermis and the common condition of cellulitis. We get the classical signs of a red, hot, tender foot, but also look for lymphangitis that manifests as a red streak along lymphatics, as well as lymphadenopathy. Now, 3 out of 4 of the main lymphatics that drain the foot drain directly to the inguinal lymph nodes. and one, the posterolateral aspect of the foot, drains into the popliteal. There are some well-trained diabetic patients that know they have an infection of the foot when their lymphatics are up and they get groin pain. Group A strep and staphylococci are the most common organisms. Next, we have a live and limb-threatening soft tissue infection that affects the fat and deeper layers and deeper fascia, and sometimes the muscle as well, and that's known as necrotizing fasciitis. The most common type is type 1, which is polymicrobial. Type 2 is monomicrobial and is usually group A streptococci. Beware of types 3 and 4. Miller mentions marine MRSA, whereas in some literature it's Clostridium, gram-negative, and fungal. Now, diabetes is by far the most common risk factor, and the lower extremity is the second most common area affected after the perineum, which is also known as Fournier's gangrene. Now, the most common red flag symptom is pain and tenderness that is disproportionate to what would you expect from cellulitis, even in diabetics. So if you see a diabetic in pain, you need to worry. Blistering and sepsis come later, but are also quite common. Now, the dishwater pus, which is more runny pus than normal and a bit soapy from dissolved fat, and gas gangrene and capitus are less common. Now, there is a biochemical score known as the Laboratory Risk Indicator for Necrotizing Fasciitis, which is composed of 6 markers and 6 parameters, such as CRP. And if you score 6 or more, then there is suspicion of necrotizing fasciitis. For example, if you score 4 for a CRP more than 150 and White's count is more than 25, then you have 6. Now, management involves resuscitation, antibiotics, and surgery, and any delay can result in increased mortality. Now, this is a classic case of an 80-year-old diabetic who was treated with foot ulcers in the community and presented with confusion. And you can see areas of established skin necrosis, purple skin discoloration, and impending necrosis. Very tender to touch, and in this case, crepitus. And you can see gas in the soft tissues on plain ankle X-ray. Now, these patients need extensive debridement, plastic reconstruction, and some end up with an amputation. Now, this is a much more frequent presentation of an 78-year-old diabetic with a painful and very tender foot, and septic with a tiny piece of glass attached to the skin. Now, that purplish discoloration is a concern with regards to impending subcutaneous necrosis. And the MRI, although there is no need, shows the extensive superficial infection involving the fat layer, but also much deeper infection involving the muscles of the foot. So the patient underwent a second amputation, debridement of the sole of the foot, and did well. But if the patient was left for a few more hours, then you would get into a situation like this, where you have irreversible skin and tissue loss, and hence they say time is tissue. Again, the patient is diabetic with a painful and tender foot and septic, as always, on a Friday afternoon. Now, he required urgent debridement on the ward, and the next day, he underwent more thorough debridement in theatres, and you can see the extent of polymicrobial infections in such necrotizing cases. And with the assistance of bactericin and a split skin graft, it healed, but has lost a toe and required 2 procedures. Now, an acutely inflamed diabetic foot with progressive tissue and skin necrosis and systemic symptoms is also known as a diabetic foot attack, which includes all the cases I described earlier for necrotizing fasciitis. And it's called a diabetic foot attack in order to convey an urgent sense of emergency, like a heart attack or like a stroke. Also, when it comes to debridement of the diabetic foot, in the exam, you can also mention the traffic light red, amber, green model of debridement, where you debride or you excise the red, which is the necrotic non-viable tissue, the amber, which is the sloughy, fibrous tissue with unpredictable viability, and you leave the green, healthy, bleeding tissue. So we covered infections from nail to deep fascia, and now we're down to bone. And osteomyelitis literally means inflammation of bone and marrow that is caused by an infectious organism. Now, it can be classified by route of transmission, by the time it's been present, and by the location of the bone and the physiology of the host. Now, by route, you can classify osteomyelitis into hematogenous, which is via the bloodstream, almost exclusive to pediatric patients, and involves the area around the knee, and in adults will be the axial skeleton. So it will be the spine, the sternoclavicular joints, the pubic symphysis, the SI joints. Then you have osteomyelitis that has developed by direct inoculation of organisms to the bone, such as in open fractures during fixation of bone or introduction of a prosthesis and penetrating trauma. And finally, we have osteomyelitis arising from a contiguous spread, such as a septic joint or infected ulcer. Now, in the foot and ankle world, contiguous spread via an infected ulcer is the most common mode of spread. Now, next, I'm just going to talk about the pathophysiology of osteomyelitis, just to understand the distinction between acute, subacute, and chronic. So let's imagine you have a nidus of infection in the medullary cavity that spreads to the cortex and to the subperiosteal area. An abscess can then be formed, surrounded by hypervascular granulation tissue, and that's what is known as a Brody's abscess, or sometimes labeled as subacute osteomyelitis. Now, the raised intraosseous pressure, vascular congestion, and periosteal elevation can result in bone necrosis. When this happens, then you enter the chronic phase of osteomyelitis. Now, when a piece of dead bone is separated from healthy bone, it is known as a sequestrum. The sinus can be formed where the sequestrum can discharge to the skin. New reactive bone can be formed, and this is known as the involucrum. Now, defects in the involucrum or the cortex, they're known as cloacae, and it means sewer in Latin. Now, the physiologic classification of Cerny and Maeder divides osteomyelitis into, the anatomic classification of Cerny and Maeder divides osteomyelitis into medullary, which has no cortical involvement and is usually of hematogenous spread; superficial, which has cortical involvement and is usually contiguous from a soft tissue infection; type 3, which is localized, which is corticomedullary, and you have full thickness cortical sequestration; and type 4, which is diffuse, which involves a whole segment of bone. Now, the physiologic classification by Cerny and Maeder divides osteomyelitis into class A, class B, and class C host. Now, class B host is compromised, and it can be compromised either systemic or local way, or both. And common risk factors are diabetes and smoking. So you have 4 anatomic types, you have 3 physiological classes, and therefore you have 12 overall stages. And stage 3B, which is the localized and a compromised host, is a common stage that we normally see. Now, radiographic appearance of osteomyelitis could be absolutely normal in the early stages, but other features might include soft tissue swelling, osteolysis, pathological fractures, periosteal reactions. Now, this is my favorite sign. This is a patient who had K1 fixation of a 5th metatarsal fracture and developed an infection that required debridements locally. Now, if you go through the early x-rays, you can see a sequestrum, which is a sclerotic, avascular piece of bone surrounded by a halo of radiolucency, and a sequestrectomy is sometimes what is actually needed. Now, on the right, you can see thickened, expanded first metatarsal and features of an involucrum, which is new healthy bone formation. Now, within the involucrum, there may be sequestry, and this will be your primary surgical target, not the actual involucrum itself. Now, a lot of time you see quite extensive changes, such as in those 2 cases. We have gas in the soft tissue, you have periosteal new bone formation and reaction, you have joint and bone distraction, you have fractures, and you have cortical erosions. Now, this is a case of a young adult who had a penetrating injury to the medial side of his foot when he fell into a river in Cambridge, and he was referred with a lateral discharging sinus. And as you can see on the CT scan, medially there is cortical erosion, there is a sequestrum, and there's a sinus tract that's communicating from medially to laterally, where you have the lateral discharging sinus where all the sequestri are discharging. Now, this is a patient with a plantar fourth metatarsal ulcer, whose normal foot x-rays I have shown you earlier. And on the top, you have a fluid-sensitive sequence, which is a T2, and you can see that the fourth metatarsal has a high signal on T2 and has a low signal on T1. And these are classical changes of osteomyelitis on MRI. Now, this is a case of a man who was caught in the middle of an explosion in Iraq, and he sustained multiple shrapnel injuries, including his brain. And he had multiple operations for fractures, and he presented with a medial discharging sinus. Now, an MRI first is contraindicated because of the multiple shrapnels, especially in his brain. And second, it won't be very useful, the MRI, because of all the metal artifacts. And therefore, he underwent a PET-CT, which is positron emission tomography CT, which is a combination of CT with administration of a radioisotope, and in this case is fluorine-18 deoxyglucose, which localizes in hypermetabolic tissues. And this demonstrates nicely the sinus and the active pieces of bone that can act as surgical targets. Now, overall, the most frequent organism causing osteomyelitis is Staphylococcus aureus, but certain organisms are associated with certain conditions, and the microbiology does come very frequently on MCQs and EMQs. For example, penetrating injuries highly associated with Pseudomonas, foreign body associated infections, implants, coagulase negative staphylococci, and Propionibacterium, and so on and so forth. Now, the management of acute osteomyelitis is usually medical, with biopsy, antibiotics, unless there is an intraosseous or subperiosteal abscess that needs draining. So next, we'll touch on the management of chronic osteomyelitis. And as we discussed earlier, the most common category of osteomyelitis we see in the foot and ankle is the contiguous type. And this is a case of a diabetic heel ulcer with exposed necrotic calcaneum. And in these chronic cases, you tend to see markings on the skin from past flare-ups of soft tissue infections, and that is common in chronically open wounds. Now, on MRI, you can see cortical erosion. You can see high signal changes on T2 weighted images of the calcaneum, and you can see multiple microabscesses. Now, when you see this image of an ulcer in your vulva, you have to use a universal language to communicate and describe a foot ulcer. And one of them is the SINBAD system, which is recommended by NICE. It describes the anatomy, so sight. In our case, is the hindfoot, so we score 1. Area, it's more than 1 centimeter square, so we score another point. Depth, it probes the bone and you can actually see bone through the wound, you get another point. In our case, there's no evidence of ischemia, he has both palpable pulses, he's neuropathic, so you get another point, and he's infected, you get another point. So you have 5 out of 6 he scores. Now, if you score 3 or more, it's regarded as a severe diabetic foot ulcer. It's reliable, the SINBAD score, and can predict ulcer healing and the risk of amputation. Now, the second thing you need to mention with regards to diabetic foot ulcer infections is the severity, which could be either mild, moderate, or severe. And all microbiology guidelines on appropriate antibiotics are based on this division. So in mild infection, the ulcer is superficial, which means it doesn't go to bone, joint, tendon, or muscle. And there is less than 2 centimeter cellulitis. In moderate infection, it's a deep ulcer or more than 2 centimeters of cellulitis. And severe infection is any of the above with systemic signs of sepsis. So in our case, it's a moderate infection because it is deep. and it's also there's less than 2 centimeters of infection. Now, the third thing you're going to have to mention is that the management of such cases is via the multidisciplinary foot care service, which is composed by a whole array of specialists as per the NICE guidelines of 2015 and update of 2019. Now, the management of chronic osteomyelitis involves 5 stages. Stage 1 is thorough debridement of non-viable bone. Then you have deep microbiological sampling. Then dead space elimination, then soft tissue cover, and then correct antimicrobial therapy. So in our case, the dead bone is debrided to healthy bleeding bone. And as you can see on the image, you can see this paprika sign, which is this painted bleeding of the calcaneum. After specimens are taken, antibiotics are given, and you start broad, and then you narrow it down depending on your cultures. Now, just to emphasize a few points on sampling, in elective and semi-elective cases, we stop antibiotics 2 weeks pre-op, if possible. We start by excising the ulcer and its edges, and we send the specimen for histology. And we came across a few cases of malignancy, such as epithelioid sarcoma and squamous cell carcinoma. Then we send deep tissue and bone samples for microbiology, minimum of 5, as well as a bone sample for histology. In our hospital, we have pre-packed forceps and scalpels for each specimen. Also, avoid using suction devices, swabs, and fingers in the wound while taking the specimens, and also touching the edges of the skin with your forceps. These are just measures to reduce cross-contamination and get a meaningful biopsy result. Now, the dead space in the bone is then filled, in this case with the gentamicin loaded biocomposite. And local antibiotics have had a resurgence in the management of osteomyelitis over the last few years, since they result in high antibiotic concentrations at the site of infection. They reduce the risk of systemic exposure, and especially in diabetic patients, they're not relying on compliance, on gut absorption, and on blood delivery, which can all be a problem. Then we close the skin defect, in this case with the help of a plastic surgeon colleague, where a lateral calcaneal flap was used. Wounds have healed, the patient is infection ulcer-free and able to return home and maintain some independence. Now, staying on the topic of osteomyelitis, these are examples of atypical cases who presented to their local hospitals with heel pain, and they were treated for months as plantar fasciitis. The first one is a 75-year-old lady, originally from India, no ulcer, and 6 months after presentation, you can see in the X-ray lucency in the calcaneum. The second case is a 96-year-old, type 2 diabetic, again, no ulcer, but X-rays show a lucency in the calcaneum, and MRI shows high signal changes on T2 and a large intraosseous abscess. Now, in the first case, the organism identified was Mycobacterium tuberculosis, and unless you ask your pathologist and microbiologist to look for it on histology and cultures, you will not find it. In the second case, the organism identified was Trichophyton interdigitale, which is the same organism that causes onychomycosis and tinea pedis. And again, you have to ask to look for it, otherwise you will miss it. Next, we have mycetoma. It's otherwise known as Madura foot, because the first case reported was in Madurai, India. Now, it's a progressive, it's destructive infectious disease of the foot, and it's prevalent in areas of what is called the mycetoma belt, which is around the equator, and is an area which is characterized by short rainy seasons and prolonged dry seasons, and that favors the growth of thorny bushes that can cause traumatic inoculation in communities who walk barefoot. Now, these are examples of cases that came through our clinic. They're all patients from the mycetoma belt, Brazil, Bangladesh, Pakistan, and appearances will include swelling, indurated skin and discolored skin, and discharging sinuses. Now, this can be quite infiltrative and destructive. And you can see the case on the left with the posterior medial ankle mass eroding into the subtalar joint. And on the right, the infection has invaded almost all bones in the foot. Now, identifying the organism is key and is important, and biopsy is very important. But histology and cultures can be negative for filamentous bacteria and fungi, and sometimes you need molecular tests to identify the organism, like in these cases below. And samples have to be sent to reference mycology labs such as Great Ormond Street and Bristol. The 16S ribosomal RNA will detect bacterial species and 18S ribosomal DNA fungal species. Now, treatment in such cases requires prolonged antibiotic therapy, fairly low cure rates, and surgeries performed sometimes from small and well-localized lesions, or to reduce the disease burden. Lastly, I just want to talk about penetrating injuries, which are fairly common in the foot, and they usually happen with nails, sewing needles, broken glass. They can cause infection, they can cause foreign body granulomas, or they can cause injury to underlying structures such as nerve, vessels, and tendons. Now, Pseudomonas is the commonest cause of osteomyelitis secondary to puncture wounds. Penetrating injuries in water, you have a Pseudomonas species, Aeromonas hydrophila, and Mycobacterium avium. Don't forget to ask about tetanus immunization. These are Clostridium-prone wounds. And diabetics have a massive risk of having an amputation after penetrating injuries. If the penetrating injury is delayed or is deep, or you think there's retained bodies or heavily contaminated, then surgery and antibiotics are required. Now, with regards to penetrating injuries, you can divide the foot into 3 zones. Zone 1 is the forefoot, zone 2 is the midfoot, and zone 3 is the hindfoot. If you have penetrating injuries on zone 1 and zone 3, you're more likely to get osteomyelitis because obviously the bones are more superficial. If you get a penetrating injury in the midfoot, you tend to get nerve, vessel, tendon injuries, or sometimes septic joints. Now, this is a case of a 41-year-old who was playing barefoot on grass in France one holiday with his son. And he had a penetrating injury in zone 2 at the sole of his foot with a tree trunk that went approximately 4 centimeters. In 2019, he developed pain and swelling at the sole of the foot, which settled within a week. And then later he developed a posterior medial ankle sinus from which there was discharge. And he had that debrided multiple times locally. You can see that longitudinal scar. But obviously the sinus was keep recurring. So he had an MRI scan, which demonstrated, as you can see, a deep foreign body granuloma in the sole of the foot, and actually a sinus tract that was communicating with that posterior medial ankle ulcer and sinus. Now, the specific area of foreign body granuloma was localized under ultrasound. In a similar way, you're trying to localize a sequestrum and try and avoid exploratory surgery in general, and especially in osteomyelitis and infection. Now, you can see here the clear communication between the sole of the foot and the posterior medial ankle, as well as a piece of bone that was retrieved from the sole of the foot. And the organism isolated is an organism that usually grows on plants and plant material. So finally, for any infection of the foot and ankle, always think about 3 things: location, microbiology, and host. Consider cultures of fungi, AFB, histology, and molecular tests. Otherwise, you will miss something. Time is tissue in the diabetic foot attack and necrotizing fasciitis. Know your microbiology. I know it's boring, but it really comes it's very common in the MCQs and the EMQs in the exam. Be comfortable about talking about the diabetic foot ulcers, how you score them with the SIMBAT score, the severity of infection, and the management using NICE guidelines with multidisciplinary diabetic foot care service. And also be able to talk a bit about management of chronic osteomyelitis, and the 5 cases and the 5 stages that we discussed earlier. So that's me, Ian.
Okay, so thanks, Con. That was an amazing lecture there. Some fantastic points of reference for the exam and day-to-day life, even as an orthopaedic consultant. So a couple of questions we had come through were, do you think there's a role for MRI in the management of necrotizing fasciitis?
Not really. It's very much like necrotizing fasciitis is very much like kind of compartment syndrome to me. It's mainly a clinical diagnosis, and then you can use your, you can use your various scores to, like, pieces of jigsaw in a puzzle. But an MRI, one, it can cause delay. If you're in a unit, we can have an MRI as quickly as an X-ray, fine. But if he's waiting for a day or two to get an MRI scan, probably it's not a great idea. So no, delay, it causes delays. I don't think it gives you any more information, and clinical history and clinical examination is probably vital.
Excellent. Okay. Another question here is about if you get osteomyelitis in a toe with no penetration or portals of entry, how does it get there?
It's very, you have to think a lot about hematogenous osteomyelitis in the phalanges of the toe. Calcaneum is probably the most common bone in the foot, and then is the talus, and then the metatarsal. So phalanges, you have to start worrying about tumors, you have to worry about gout, you have to worry about other things. Without an ulcer, a repetitive injury is quite unusual.
Okay. And just from a personal point of view, you obviously work in a tertiary referral centre and see some problems that come from other centres. What's the take-home message you give for consultants in what do they miss most often that you think, oh, I wish they hadn't missed that? What's the most common thing you see is mismanaged? Well,
it's unfortunately, one thing that we see very often is the very common use of vac dressings, where vac dressing is a dressing. It's like an inidine, a Mepitel, a gauze. It's not a treatment for osteomyelitis, and we see that fairly often. The vac dressing for weeks and weeks and weeks, which is not an actual treatment; it's a form of dressing. And as I discussed earlier, the stage, if you have necrotic bone and it becomes chronic, it's very difficult to cure it unless you undergo surgery. So I think we see that quite often. A back dressing is not a treatment for osteomyelitis. It's just a simple dressing, and it just delays things. Any worries, concerns, you refer them to people who deal with them more often. I think that's probably the most, the take-home message. Obviously, with diabetic feet, we're all part of diabetic foot surveys, and obviously the volumes and the numbers are huge. But non-diabetic foot infections, yes, it might be worth referring to people who deal with them more often, and they have a unit or a group of people surrounding them that can actually manage those patients in an MDT way.
And a question just come through about diabetic ulcers, and the question is, at what stage do you think an ulcer should be taken for surgery or debridement rather than being dressed by the diabetic nurses? I suppose it goes back to scores and things like that, doesn't it, really?
Well, yeah, exactly. And the question is why, is correcting everything you can. Why a diabetic has an ulcer, and it's about the diabetic control, it's about the perivascular disease, about offloading, it's about appropriate care, it's about debriding, it's about antibiotics, taking specimens. So there's a whole array of things before you actually reach, the knife and the operating theatre. So, yeah. So, that's it. I think it is a very difficult to have a recipe of who do you take theatres and who do you manage conservatively, because every patient is different. But you always start with the non-operative measures and with trying to improve what you can.
Excellent. Okay, so I think we'll close the questions there and maybe move on to the case studies and case presentations. Thank you, Con. It's excellent. There'll be some time for more questions at the end, I'm sure.
Of course, no problem.
So the one question we had was, is there ever an absolute indication for amputation in osteomyelitis? Was a question we had from the audience earlier on.
Well, I mean, I've been a consultant for, I think, 3 years or so, and I've done 2 billion amputations so far. So I think if you all salvage options have failed and you're unable to eradicate infection, then you probably cannot have a stable foot, a functional foot you can put in a shoe, then that would be the indication for an amputation for infection. Because especially the population we deal with, those diabetics, neuropathics, frail old, a below-knee amputation would mean probably not going back home, not be able to walk again, and back to a care home. And it's a bit of a disaster for those kind of patients. So, yeah, I mean, I think when all salvage options failed and you cannot eradicate infection, that's probably the only indication. And if you have a foot that's not stable, not functional, not showable, then that would be my indication for amputation. I don't know what you think, Mark, but
I pretty much agree, Con. Actually, it's social care as well, isn't it? It's important to consider these patients. It's not just life terminal for these patients, but it's where they live, who looks after them as well. But always consider it, but never done lightly. Never done lightly.
Do you chaps do your own amputations, or do you get a vascular surgeon and plastic surgeons involved?
Mostly our own, actually. For complex ones, I've got plastics involved before, but mostly our own.
So a bit of an issue in our trust at the moment, but that's another topic.
Yeah.
Okay, so we've come to the end of our hour now, so I'd like to thank the speakers from Oxford, Mark and Con. Excellent talks and some good points for our learning for exams and for life in general as an orthopaedic consultant. And I'd like to thank Bone Support for their support of the evening. And if you go to the chat screen, there's a link in there which you click. That'll take you to your feedback form. When you fill that in, you'll then get a certificate for your CPD. So thank you. And next week, the lecture distinction is by Manish Bhatia, who's going to talk about foot and ankle tumours. 8 o'clock next Tuesday. Put it in your diary. It'll be worth attending. Thank you very much.